for attending. Can everybody hear me well? I just want to make sure I'm loud enough. Great. My name is Abisola. Most people call me Abby. I'm a sickle cell patient, and I used to live in Calgary. And so I'm going to be moderating the second half of the day today, as Bernice mentioned, which includes the presentations. After each presentation, we'll have time for people to ask questions. So you can put in the questions in the Q&A. And we will likely only be able to take 1 or 2 questions in the interest of time. And for the other questions that you do have that we don't get to, please still put them in the Q&A chat. We'll get them to the presenters and get responses and get that published on our website. So our first presentation is going to be from Dr. Turner, and Dr. Turner is a hematologist in Alberta. He was born in Brandon, Manitoba, went to school, initial schooling at Carroll and Napawa, Manitoba. He then went to the University of McGill, where he studied medicine. He completed his postgrad in internal medicine at the Royal Victoria Hospital in Montreal. And then did a hematology and oncology fellowship at the University of Pittsburgh. Dr. Turner has held a bunch of appointments, a lot of appointments throughout his career. One, he was a professor of medicine of pathology and oncology at the University of Alberta, director of CRC blood transfusion service in Edmonton until 1995. He was the director of the Division of Hematology at the University of Alberta from 1984 to 2002. He was also the director of stem cell transplant program at the Cross Cancer Institute, and that was from 1980 to 2015. In addition, Dr. Turner was most recently an MLA in Edmonton in the Riverbend region. Dr. Turner is going to be presenting on the future CRISPR-Cas9 and sickle cell anemia. Thank you, Dr. Turner, for joining us today.
Well, thank you, Abby, and I really appreciate this opportunity. And I want to congratulate the Sickle Cell Foundation of Alberta on organizing such a great meeting. Actually, I'm really enjoying this so far, so I'm looking forward to the other presentations. As Abby indicated, I have a long history association with sickle cell patients. I actually learned all about sickle cell disease when I was doing my hematology training in Pittsburgh, and we had a sickle cell clinic at the University of Pittsburgh Medical Center. I was fortunate to meet there John Akabutu, and I came to Edmonton in 1977, a long time ago, and worked with John Akabutu and with people like Dr. Jean Walrond and others in caring for patients. I know Michelle Patterson-Knipp very well, and I've continued to have a really fruitful association with the sickle cell group. Today, I want to talk about something that's really exciting, and I think that many of you will be interested in, and that is this new CRISPR-Cas9 gene editing process that helps, that has the potential to really be a helpful treatment for folks that are suffering from sickle cell disease. So we'll start with there's 2 audio files that I want to share with you. We'll start with one now.
Okay, the first person to get treated in one of the most closely watched medical experiments in decades is now waiting to learn if the treatment is working. NPR health correspondent Rob Stein introduced us to Victoria Gray this summer, and now he continues his exclusive look at her story.
Hi, good to see you.
Good to see you too.
I catch up with Victoria Gray in an apartment in Nashville near the hospital where she volunteered for the first attempt to use the revolutionary gene editing technique called CRISPR to treat a genetic disease in the United States. Thank you so much for seeing us and letting us come over. I really appreciate it.
No problem.
Victoria's packing. She's finally going home tomorrow to see her 4 kids in Mississippi for the first time in months.
I'm excited, I'm very excited about it. I know it's going to be emotional for me. I miss the hugs and the kisses and just everything.
It must be so exciting.
Yes, I am. Yes, I am.
She unzips a suitcase and starts pulling clothes from the closet.
Oh my goodness, did I really bring all of this?
Victoria has sickle cell disease, a terrible genetic disorder that turns her red blood cells into deformed sickle-shaped cells that clog her bloodstream, ravage her body, and torture her with agonizing bouts of pain.
The pain is excruciating. It's like being in a car accident and having lightning in your chest. It's pain that makes a grown woman like me scream.
Oh my God, that just sounds terrible.
Yeah, it's an overwhelming pain.
Like many sickle cell patients, Victoria had to drop out of school, quit work, spend weeks in the hospital away from her kids, worry whether she'll live to see them grow up.
It's horrible.
You have to live with that every day.
Yes, knowing that I can have a stroke or a heart attack at any time because I have these cells in me that are misshapen. Who wouldn't worry?
But now, Victoria has hope because doctors infused billions of her own cells back into her body this summer. Cells Victoria calls her
super cells.
Because scientists altered a gene in the cells with CRISPR, which makes rewriting DNA really easy, to hopefully give Victoria normal, healthy red blood cells.
Super cells, yes. Yes, they gotta be super, do great things in my body. And to help me be better, and help me have more time with my kids and my family. That's one.
Her suitcase done?
Yes.
But before Victoria can finish packing and go home, she has to stop by the TriStar Centennial Medical Center in Nashville again.
So how have you been doing?
I'm doing good.
So, this is a big moment, friend.
Yes.
Dr. Hyder Frangul at the Sarah Cannon Research Institute treated Victoria.
Are you excited about seeing the kids?
Yes, I am.
A big welcome sign for you in Mississippi?
No, because it's a surprise. No one knows I'm coming.
You did not tell them?
No.
Oh, wow. So they don't know you are coming?
No. I'm just going to show up tomorrow like Mama's home.
That's pretty good. Okay, let's check you out.
Okay.
Take a deep breath for me.
Dr. Frangul says Victoria will come back once a month for checkups and blood tests to see if her supercells are producing something called fetal hemoglobin.
We are very hopeful that this will work for Victoria, but we don't know that yet.
So Victoria will also keep detailed diaries about her health, how much pain she's having, how much pain medication she needs, blood transfusions.
Victoria is a pioneer in this. We are very excited. This is a big moment for Victoria and for this pivotal trial, because if we can show that this therapy is safe and effective, it can potentially change the lives of many patients.
Dr. Frangul will also watch over Victoria for years to see if the treatment is preventing organ damage, heart attack, strokes, and other complications that take the lives of sickle cell patients, and for any signs of any side effects from the treatment.
My hope and dream for Victoria is to allow her to spend quality time with her family, go to the park with them, play with them, without having to struggle with pain and weakness. I would love Victoria to be able to live a healthy, normal life, and she can see not only her children's graduation from high school, but from colleges and getting married and having grandkids.
Victoria hopes so too.
Not just for me, but for other people. This would be mind-blowing. And oh my God, I can't imagine, the lives that could be saved if this thing actually worked.
That would be amazing.
Yes, it would be.
Now it's time for the nurses to get some of Victoria's blood for the study she's in. It's being conducted by 2 biotech companies and will eventually involve dozens of patients in the United States, Canada, and Europe.
All right, so how many days have you been here?
I think we're in like day 80.
Oh, I can't believe you're really leaving.
As nurses Bonnie Carroll and Brooke Ryan fill one big vial after another, I realize I never asked Victoria something.
Is it weird to have genetically modified cells in your body?
No, I'm just genetically modified now. I'm a GMO. Is that what they call it?
Finally, the nurses are done, and it's time to say goodbye for now.
Good job, you did it.
Thank y'all. Y'all gonna make me cry.
Oh. You're right.
But before I say goodbye to Victoria, I ask her about what comes next, this limbo period, waiting to find out if her supercells are working.
Well, I'm spiritual, Robin. It's something I prayed about, and just the way everything happened for me, I just feel like it was fate for me to be here. I just believe that, God is doing this for me. That's all I can say. So, yes, pray.
Rob Stein, NPR News, Nashville.
And now, more from NPR.
Live from NPR News, I'm Barbara Klein. Arizona's top election officer is calling for an investigation into
Well, that video or audio file actually covered a lot of the information that I want to get across today. I'm just going to give you these slides that I've prepared, really give you some background information to that. And this first slide, I'm sure all of you understand a lot of it, but I find it interesting that it's really only maybe 110 years since sickle cell disease was recognized as a blood disease. And in 1910 in Chicago, a young dental student from Grenada was the first person that was found to have sickle cells in their blood, and he presented to the emergency room with a painful episode, which I'm sure a lot of you are familiar with. So it goes back to 1910 when it was first recognized, and it wasn't until 1927 that it was recognized that the deoxygenation was what the removal of oxygen from the red blood cells was what caused the red blood cells to go into the sickle shape. As was stated in the questions in the intermission, sickle cell disease is inherited. It's not acquired. And in about 1950, the actual molecular disease was described by Linus Pauling, who won a Nobel Prize for doing it. I think the most important advance, and the one that we want to talk about today, was the recognition that hemoglobin F, or the fetal hemoglobin, the hemoglobin that's present in babies when they're living in utero, is the kind of hemoglobin that protects against sickling. So it's one of the reasons why babies are able to survive even if they have homozygous sickle cell disease in their mother. Can I have the next slide, please? So this is just a picture of what happens when the sickle hemoglobin forms these very stiff red blood cells that have difficulty passing through the blood vessels, and they actually cause obstruction to flow, and that obstruction can happen in the bones and cause a painful crisis, but it can also happen in the lungs or in the brain or in the kidneys and elsewhere, and really cause this sickled red cells and their obstruction is really what causes disease. Next slide, please. So this is a graph of the types of different of hemoglobins that are present before birth and after birth. And basically what this is describing is that there's a genetic process that it's called hemoglobin switching that happens at birth, so that the production of the gamma globin, which is important in, which is a component of hemoglobin F, falls off. And so by 6 months, it's been replaced primarily by the beta globin, which is the kind of globin that carries the sickle gene abnormality. And this 6-month period is really when babies most often present with painful hands or other crises, and it's when the disease starts for many folks. Next slide, please. So this is again probably saying the same thing, but it's that if you've got a lot of fetal hemoglobin-bearing red cells, it prevents the obstruction of the blood vessels and can prevent things like stroke and the chest syndrome, as well as bone pain. And basically what this CRISPR therapy does is to change the patient's bone marrow cells into producing enough fetal hemoglobin that the vaso-occlusion is prevented. If I can have the next slide, please. So just going through some of the crises, some of the advances in treatment, basically 1950 and beyond, the only treatments that were available were red cell transfusions. The red cell transfusions don't provide fetal hemoglobin, but they provide enough normal hemoglobin to basically dilute out the sickle blood and help treat the crises. So around 1980, the medication hydroxyurea was introduced, and interestingly, it actually causes an increase in production of the fetal hemoglobin. There's another situation that occurs basically in nature, and that is there are some people that are born with a gene that actually allows them to have persistence of the fetal hemoglobin throughout life. And many of these folks come from the Middle East, particularly Saudi Arabia. And it was observed that these folks actually have very few problems with sickle cell disease, even though they carry 2 sickle genes. So around 1990, the first bone marrow transplants were done in Italy, in Greece. These bone marrow transplants are the kind of bone marrow transplants that have to come from donors, usually from brothers or sisters, and they carry a risk of a serious disease called graft versus host disease. But these bone marrow transplants, and we've actually had one done in Alberta a few years ago, and they have been successful for a large number of folks. In 2013, the actual technology of the CRISPR process was invented, if you wish. And as we saw in the video, the first CRISPR-edited autologous stem cell transplants were done. So if I could have the next slide, please. So what CRISPR does is basically creates a small piece of RNA with a sequence that binds to a specific target in the DNA of the bone marrow stem cells. And this RNA sequence also binds to an enzyme called Cas9 that cuts the DNA at the specific part that controls the production of fetal hemoglobin. So once the DNA is cut, basically the process involves the patient's own DNA repair machinery to make these changes. If I could have the next slide. So the process is quite complicated. So hematopoietic stem cells, that's basically the stem cells that make the red cells, white cells, and platelets. And the red cells are the ones that make the hemoglobin. They're collected from a patient by a process called apheresis, which is basically the collection of peripheral blood cells. And this is something that is done several hundred times a year here in Alberta at the cancer centers, because this autologous stem cell collection is very important in the treatment of leukemias as well as lymphomas and myeloma. It isn't only sickle cell disease that can be treated with this. Some beta thalassemia patients also benefit from this process. And remember, the process is not to fix the sickle cell process, but to turn on the fetal hemoglobin production. So once that's done, the stem cells are frozen and stored, and they can be frozen for a long period of time or for just a few days. But in order to make this process work, the patient has to be treated with enough chemotherapy to basically suppress their normal bone marrow. And this makes them susceptible to problems with infection or with bleeding, but it only takes about 3 weeks for those stem cells to take root and start to produce the red cells, white cells, and platelets that they need. So that's basically, I've sped through this, and I want to show a second video that shows how Ms. Gray was doing this past summer.
You're healthier. Today, it's
has been sheltering at home in Mississippi with her children, like millions of others. But she is not like any other American. Victoria Gray is the first person with a genetic disorder to get treated in the United States with a revolutionary gene editing technique. NPR health correspondent Rob Stein introduced us to Victoria last year when he got exclusive access to tell her story. Today, we hear how Victoria has been faring.
the last time I saw Victoria, her doctors were just finding the first hints her experimental treatment may have started working. But the big question was it really working? And was it really making her healthier? Today, it's been almost a year since she got treated, and the news couldn't be better. Almost all the complications of the terrible genetic disease she was born with have essentially disappeared.
It's wonderful, it's the change that I've been waiting on my whole life.
Victoria's 34. She was born with sickle cell disease, which turns red blood cells, the cells that carry oxygen, into deformed sickle-shaped cells that get jammed inside blood vessels, causing horrible attacks of excruciating pain.
Before the treatment, it would be so bad, it would be crippling.
Victoria knew many sickle cell patients die young from the damage the disease wreaks on their bodies, so she volunteered to let scientists infuse billions of her own bone marrow cells that had been modified with a gene editing technique called CRISPR back into her body to hopefully give her healthy red blood cells. And Victoria can hardly believe that it looks like it actually worked.
It's a very big deal, Rob. It's a very big deal for me because now I feel like I can just live, and plan for the future.
Victoria hasn't had any of those terrible pain attacks since she got her new cells, hasn't needed any blood transfusions, gone off almost all the powerful pain drugs she's needed to get by.
I haven't had to be in the hospital or go to any emergency rooms, so I've been able to stay at home with my kids and do more. It's a huge change.
A huge change that in some ways came just in time. Right after she got home to Mississippi from the hospital where she got treated in Nashville, the National Guard deployed her husband to Washington. And then the pandemic hit. Victoria was suddenly home alone with 3 of her kids.
But one thing I did have to do was become a teacher. So that was hard, trying to navigate education for the kids while they were out and working with the teachers to make sure they didn't get behind. And focusing on staying safe.
Her great aunt died from COVID-19 early on, so did a pastor. Friends at her church have been getting sick, and even though her immune system is still weak, Victoria has to keep going to buy the family groceries. And then George Floyd was killed by police in Minnesota. At times, Victoria says, it feels overwhelming.
I feel like everything happened so fast. Like, I was trying to recover, and my husband had to leave. Then the pandemic hit. Then, the death of George Floyd, and the protests and rioting, and it's a lot. So it hasn't been easy.
And maybe the hardest part has been trying to help her children understand all this.
Having to explain to my kids, about safety just because of their skin color. That's hard. That's been one of the hardest things for me. It's heartbreaking for me. And I'm sorry, Rob. And it's hard to explain to them, and sometimes you can't find the right words.
But if she hadn't had the treatment, Victoria doesn't know how she'd be coping. She would have been too weak to care for her kids, probably ended up in the hospital when hospitals were never scarier.
And since my treatment, I've been able to do everything for myself, everything for my kids. So it's been joy not only for me, but for the people around me that's in my life.
Now, Victoria's just one patient, and she'll have to be followed for years to make sure the treatment continues to be safe and keeps helping her. But the fact that the edited cells have now been working so well for so long has made her doctors far more confident that her gene-edited cells are really doing what they'd hoped and will keep working for Victoria and other patients.
It's hard to put into words, the joy that I feel in being grateful for a change this big. It's been amazing.
Victoria's now hopeful for things she thought she'd never get to see.
High school graduations, college graduations, weddings, grandkids. I thought I wouldn't see none of that. I'm sorry. Now I feel like I'll be there to help my daughters pick out their wedding dresses. And we'll be able to take family vacations. And that they will have their mom, every step of the way.
And Victoria hopes her story will give other people hope too, not just with sickle cell, but for many diseases.
We need this right now more than ever. It's a blessing to be able to know that you can one day be cured from something that you thought you could possibly have for the rest of your life, and that there was no hope. It gave me hope when I was losing it. So I feel joy, knowing that there is hope.
Rob Stein, NPR News.
Thanks, Felix. That's the end of it. Okay, Abby. You're muted, Abby.
Thank you, Dr. Turner, for that. So right now we're open to any questions that anybody attending would want to ask. Please feel free to drop your question in the Q&A and type that in there. One question to start off that I have, Dr. Turner, is, would you say that gene editing using CRISPR-Cas9 would be maybe of a lower risk than some of the stem cell transplants that are occurring today?
Well, there are different kinds of stem cell transplants. So basically, there's two different kinds. One is the what's called allogeneic, and that's a stem cell transplant that comes from somebody that isn't yourself. So it can come from a brother or sister that is HLA matched, or from cord blood or an unrelated donor. And those transplants work, but they are associated with a lot more side effects than an autologous stem cell transplant, which means that the source of the stem cells is the patient themselves. So I think this is a real advance in that regard.
Okay. One question we have from one of the attendees is, how effective is CRISPR in patients who have their vital organs already affected?
So the CRISPR gene editing will not repair will not repair the organ damage that's already occurred. But if you've got blood flowing through your arteries and veins that does not sickle, it's going to give a chance for the damaged organs to recover. And certainly that second video or the second audio file was very encouraging in that regard as to how Ms. Gray was doing.
Okay.
If I could ask Biba to see if she has any comments. That in the first audio thing, they said that these trials were going to go on in Canada, and so I was wondering if Biba knew of any work in this regard in Montreal, Toronto, Vancouver.
Well, thank you, Dr. Turner. Great presentation, by the way. Yes, we're following this closely, even though I cannot share any particular stats.
Can you speak a little bit louder, please?
Okay, yeah. So can you hear me well now?
Yeah, that's a little bit better.
Okay, so I said thank you, Dr. Turner, for this great presentation and very informative presentation. And I'm sure that the patient community has learned a lot today about this new gene editing, technique that we're all looking forward to see how it's going to help our community. So for now, I cannot share a specific site, in Canada, but yes, they are working, towards starting that. It might probably be around Ontario for now. So what I can do, though, I can share more about it with the organization, and it can be put on the website later.
Thank you, Biba. The other question that we have is, which pharmaceutical company is running this trial?
I'm sorry, I didn't hear that.
Which pharmaceutical, I'm not sure, Dr. Turner, are you aware of which pharmaceutical company is running the trial?
Biba may have more information on that. It's not a pharmaceutical company. There is a company that has the patent rights to the CRISPR technology, and I think it's called Vertex. Actually, is the name of that company. But the trial that Ms. Gray was part of was run out of I believe Harvard. And they are the lead center in the United States for doing this. But I think Nashville, for instance, is doing it. But basically, the one can expect that this technology will not come cheaply.
Yeah, very true. Okay, thank you again, Dr. Turner, for the great presentation and all the information. That was really good. And in the interest of time, we'll move on. And
well, just one further comment. Just if anybody wants more information, please don't hesitate to email me at robert.turner@ualberta.ca.
Thank you. Okay, so we're going to move on now, and I would like to introduce Stephanie Burley to give us and sing for us again. She had sang earlier, "O Canada," and so Stephanie, handing it over to you for another song and a few words.
She's on mute.
There, sorry. Okay, once again, I want to say that I'm very happy to be a part of this very important AGM. And I am really humbled by all the work that everyone is doing to make a difference in people's lives. And I don't know if you want me to sing first and talk later, or how you want me to do that. But I do want to say thank you to Dr. Robert Turner. I understand that that you have received the Mary Burley Award for community service, and I just want to thank you for the work that you are doing. I think it is so important. I was asked to talk a little bit about my mother, Mary Burley, and in whom the award is named in her honor, and just the community work that she did and the love that she had for community and the hard work that she put into it. She was a great woman and a great humanitarian, and I see that in all of you and the work that you're doing, and I think it is so, so important. I'm really humbled by all of your work and your efforts and just what it takes. And talking a little bit about my mother, Mary, I think she'd be so proud as well to know that such an award would be given to someone like Dr. Robert Turner. So there's so much that I could say about my mother. I'd like to say that she left us in 1996, so I miss her terribly. And I think that it would be, I guess I'd like to say that she cared for people. She cared for women like the young lady that was in the story. I believe she was from Mississippi, the young lady that received the new testing. And in her, I see my mother and my mother's story. So I just really want to encourage you all to continue your work and your efforts, and to Jean Waldron too, who has been so instrumental in bringing you all together, really, and starting something here in Alberta, the Sickle Cell Foundation here. All of your work is, I think history will look back on this and see that you guys were heroes in the work that you started, and that it will continue. So the song that I wanted to sing, I'm not a great speaker, but the song that I wanted to sing was a Louis Armstrong song, What a Wonderful World, because I think what you're all doing and the work that you're all doing is helping to make this world a better place. The work like my mother did, working on poverty and working for to change the lives of children and women living in poverty, and what you all are doing to change the lives of people who are living in chronic pain. It's so humbling and it's so important. So I wanted to sing What a Wonderful World. So it's a cappella, and I hope that it resonates with you all. I see trees of green, red roses too. I see bloom for me and you, and I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright, blessed days, and the dark, sacred nights. And I think to myself, what a wonderful world. Oh, the colors for the rainbow. They're so pretty in the sky. They're also on the faces of people walking by. I see friends shaking hands. They say, how do you do? They're really saying, I love you. I hear babies cry. I watch them grow. Soon they'll learn more than you and I will ever know. And I think to myself, what a wonderful world. I think to myself, what a wonderful world. Thank you.
Thank you.
Thank you so much. That was really beautiful. Both the song and the message about your mom. Thank you.
Thank you. Thank you.
Now we are going to move on to a presentation from Trudy Sales. Trudy is a nurse from the Calgary region. Trudy graduated nursing in 2005 and has specialized in the field of hematology since that time. So from 2005 to 2011, she worked in the bone marrow transplant unit at the Foothills Medical Center in Calgary. In 2007, Trudy took part with the Southern Alberta Rare Blood and Bleeding Disorders Comprehensive Care Program and helped establish the clinic from the ground up. In 2015, Trudy took a permanent role as the primary sickle cell disease nurse in the Calgary area. And then in 2017, Trudy took on a research position at the University of Calgary, assisting Dr. Ritz with research in sickle cell disease. So apparently Trudy has been very busy for all these years. And thank you. So Trudy is going to be presenting on the 21st century nursing and the sickle cell patient. Thank you, Trudy.
Thank you, Abby, for that introductory. It's a pleasure to be here. I want to say thank you to the Sickle Cell Foundation for the invitation to speak today. It certainly has been a very informative meeting. And thank you, Stephanie, for that beautiful song and tribute to your mom. I may have shedded a tear or two during the very beautiful, just very touching. So today I would just like to present on 21st century nursing and sickle cell disease. With a focus of some of the things that we are doing at our clinic and the role of the nursing in sickle cell disease. Next slide, please. So very general, very brief, as we have already heard and we all know, sickle cell disease is a group of inherited red blood cell disorders. People living with sickle cell have abnormal hemoglobin, as we know, called hemoglobin S. These sickle-shaped cells are not flexible and can stick to the vessel wall, causing blockages that slow or stop the flow of blood. When this happens, oxygen can't reach nearby tissues and causing severe pain crises, as we have heard. The red, I don't see my screen. As we know, the red cell sickling and poor oxygen delivery can cause severe pain and organ damage. And over the lifetime, sickle cell disease can harm every single organ in a patient's body. By the age of 50, it's been documented that 50% of sickle cell patients have some type of end organ damage. Sorry, I don't see my slides anymore. Abby? Felix, are you still there?
Is that better?
No, I don't see my slides.
I can see your slides.
Oh, okay. I don't see my slides. Oh, okay, now you're sharing. Okay, there we go. Thank you. Sorry about that. So as we heard from Dr. Turner, there has been many discoveries and advancements of sickle cell disease over the last century. And as such, I think the management of sickle cell disease has also changed and advanced. Certainly the nurse's role, I believe, has become more than, treatment of sickle cell disease, treating pain or assisting with treating pain. Although this is certainly a very, very important aspect. I feel as nurses, we have taken on a role to help more emphasis towards prevention and continuous monitoring for early signs of end organ damage. If we can help monitor, prevent, slow down end organ damage, I feel we can increase the patient's life expectancy and certainly help with the patient's quality of life. In the last decade, there has also been a very greater shift towards patient and family-centered care and collaboration with the patient involvement and engagement. And nurses I feel, have become a very key component in this as well. Next slide, please. So in the next few slides, I'd like to just talk about kind of our clinic, what we're doing to help improve the sickle cell care that we provide. Our clinic was established in 2007. Prior to that, most of the patients with sickle cell disease in Calgary certainly were under the care of a single hematologist or family physician or some type of primary care provider. When we started in 2007, we were just started out with bleeding disorders patients and then started to take on the hemoglobinopathy patients around I believe it was about 2010, 2012, somewhere around there. We have a focus on providing comprehensive care using the comprehensive care model, as well as components of the primary nursing model. And I'll spend some time talking about two of these models in specific as we go through the presentation. Next slide, please. Before we get into the models deeply, I just kind of wanted to give a kind of sense of how our population has grown over the years. We certainly have grown. We continue to get referrals on a weekly basis, and we are fully booked for clinics months ahead of time. On top of referrals we receive from family doctors and other specialties, we also have lots of kids that transition over from the pediatric center as we are just primary adults. I know in the next year to 2 years, we have 35 more young adults that will be coming over to our clinic. Next slide, please. So as I had mentioned earlier, our clinic has taken on what we call a comprehensive care model. This is a holistic, multidisciplinary management approach. Although the model is used widely around the world, our clinic adapted the model that is used by the hemophilia centers in Canada, which have been around for quite some time and seem to work very well. Currently, we have our clinic consists of 4 physicians, 3 nurses, we have a unit clerk, a physiotherapist, 2 psychologists, a pharmacist, and a social worker. The primary focus is on individualized treatment and prevention of any acute and chronic complications of sickle cell disease. The ultimate goal is to help reduce the number of hospitalization, decrease the length of stays in hospital, to slow down organ damage, and to increase the patient's overall quality of life and outcomes. Next slide, please. So in comprehensive care model, collaboration is probably one of the biggest things. And so we have established relationships with many specialties outside of our clinic who have agreed to be involved in the care of our sickle cell patients. They kind of have become our go-tos for whenever we need advice or a patient needing consult. It's very important, or we found it very important to have those go-tos because anytime that we have a question or a concern, we know who to call. They've done their research, they've taken an interest in sickle cell disease, they know what the treatment is, what the treatment plan should be, and it just really gives us quick access. Many of these specialists has also helped our clinic create clinical guidelines that can assist us, the main caregivers, with providing the appropriate care and management for any complications that may come up. For example, we recently created some guidelines in collaboration with our OB and gynae group for pregnancies and sickle cell disease. We have collaborated with the pain clinics to create formal approaches to pain prescriptions and management of pain. We have collaborated with the emergency departments to create individualized treatment plans, and I'll talk about that a little bit later. But certainly we are always trying to find ways to improve the quality of care that we provide for patients. And again, in this picture, I want to emphasize the patient is the biggest part of this collaboration. We do really focus on wanting patient input and collaboration with their care and their treatment plan. Next slide, please. So some of the obvious benefits that we have identified as having a program run under a comprehensive care model is it gives the patient kind of a sense of a medical home with a group of specialties that is available to give advice during business hours. The team is available to take advice or to give recommendations during business hours. Certainly the medical system is very complex and it's not easy to navigate even for those who work in the field. So we feel that it's just a way that easy access to get the help that the patient requires in a very timely manner and easier access to other specialties such as a psychologist and social worker. Essentially, the patient just needs to call our clinic, say, I'm struggling with X, Y, or Z. We would identify who would be the best specialist to attend to that need, whether it be, if it was a social worker question, we would simply page the social worker and the social worker would get in contact with the patient right away. This type of model also allows the team to address, as I said, not only those physical needs, but the needs, any mental health concerns that may arise or financial employment, the social worker drug coverage. There's a huge variety of needs that we can attend to all in one area. This type of model with the collaboration has also helped us with quality improvement projects, both formal and informal. And as I had mentioned in the previous slides, just creating those guidelines and having input from a multidisciplinary aspect. Certainly, I feel that this type of multidisciplinary management approach, it really enhances the relationship between the patient and the care team. Next slide, please. So as I had mentioned as well, in combination with the comprehensive care model that I just discussed, we also have adapted components of a primary nursing model. This model is defined as a single nurse, as is identified as the point of contact for and primary caregiver for a specific patient or population of patients. That single nurse is responsible for the planning, the implementing, the evaluating, and the management of care for that population. Currently, we have, as I said, 3 nurses in the clinic, and each of us have taken a special role with each population. So we have a primary sickle cell nurse, we have a primary thalassemia nurse, as well as a primary bleeding disorders nurse. We do all kind of still work together and we do cross cover each other. So if I'm unavailable to take a call and it's an urgent matter, then certainly one of the other nurses can. But the overall care and management is certainly run essentially by the primary nurse. We have found again that this has been instrumental in establishing a trusting relationship with the patient, and I feel that the patient is more comfortable, or over the years I've certainly kind of identified that the patient is feeling more comfortable with calling in with any questions or concerns, which is essentially what we aim for them to do. Next slide, please. So 21st century nursing obviously is just more than taking orders from physicians and providing direct care to patients. As I noted in the previous slide with the primary nursing model and the comprehensive care model, the nurses is really responsible for a whole string of things, planning, implementing, and evaluating, and thus must take on many roles within that responsibility. In the next few slides, I kind of want to just deep into some of the roles that they play and some of the things that we are doing in our clinic under each of these roles. Next slide, please. So certainly we at the clinic, nurses are care providers still, and I would say probably care providers / managers. We are the first point of contact for most patients in our clinic. When the patient calls, they are usually greeted by our unit clerk who triages the phone call, and then certainly will pass on if it's to the appropriate nurse. The nurse, myself, is available through the phone or email. I have lots of emails that come in during the week from certain patients or individuals. We do make a point to follow our patients while they're admitted to our center to make sure that we greet them, that they're doing okay, and to ensure that their needs are all being met. If there are any questions or any concerns, we certainly do address those for the patients. We are key in arranging follow-up blood work, yearly blood work, monitoring that, organizing any yearly monitoring diagnostic imaging tests. We send referrals to subspecialties as necessary. We certainly are instrumental in coordinating care for procedures such as surgeries, red blood cell exchanges, and so forth. And certainly is key in consulting with other team members as needed. Next slide, please. So our role as educators consists of, a variety of things. Educating inpatient staff on sickle cell disease and patients' needs. As I said, we do follow them when they're in patient clinic or admitted into hospital. And so certainly we will take that opportunity to connect with the primary nurse that is caring for that patient during their acute admission and to provide any education that's needed. We have really taken on a focus on educating the emergency department. Certainly we have heard many negative stories of patients' experience in the emergency department. And so we've identified some barriers to care. And so one of the things is that we try and provide educational sessions during their mandatory educational sessions. This way we know that staff have to come, so they have to hear us. We also meet with the educators in the emergency department as well as the managers to kind of discuss some of the issues or the barriers and that can help improve the care of sickle cell disease. One of the things that we just did, as I noted previously, was we created an individualized pain protocol in the patient's electronic medical chart. So essentially, whenever a patient presents to emergency department, they look the patient up on their electronic chart. There becomes a flag that says there's an individualized protocol treatment protocol for this patient. And so it just takes it directly to this individualized protocol. It kind of has taken the guessing game, I would say, out of the physician trying to determine what pain medication would be most appropriate. I mean, we keep hearing that sometimes the patients are not receiving adequate doses or frequency of doses for pain medications. And so we have put in what their disease is, why they may present, so some of the main ER presentations, just so they're not missing anything. We often will put in what their home treatment plan is and then make recommendations for what that initial emergency department pain protocol should look like. Again, obviously, we're always trying to educate the patients. This is during one-on-one clinic visits, and we just started to do some online educational sessions. Certainly in any and every interaction with the patient or other staff members is certainly an opportunity for teaching. Next slide, please. So collaborating and advocating, we have certainly taken on a focus in this in the last year or two. We have, I believe about a year ago, 2 years ago, we started an advisory committee. This was driven by Dr. Natalia Ridz, and part of the team is herself, myself, a social worker. We have representation from the Sickle Cell Foundation of Alberta, the Calgary chapter, and we do have a number of patients who sit on this board as well. or this committee. We try and schedule regular meetings, and the overall goal is to try and find if there's any issues, any concerns. If the clinic has provided any new policies, we kind of like to review those with patients to see if it's important to them, if it makes sense. And certainly any new educational materials, we will reach out to them to review beforehand before we start implementing them. We have also established a working group with the Calgary chapter, the Sickle Cell Foundation of Alberta. We try and meet regularly, and I feel like we have been kind of a key component in sending out the information, flyers, and emails. Certainly, I try to educate my patients on the foundation and try to encourage them to become involved. And again, certainly collaborating with the other specialties, as I said, I've sat on a few boards in trying to create those guidelines to improve the quality of care. Next slide, please. And finally, research. So certainly over the years, there hasn't been much in terms of research from nurses, but like many other things, I think there's been a shift. And over the last decade or so, nurses have been encouraged to participate in more research. So I'm very honored to be working alongside of Dr. Natalia Ritz as her co-investigator. And we currently do have 2 sickle cell projects on the go. One is sickle cell and pain tool, and that is looking at developing a pain questionnaire that will help not only the patients describe their pain, but also to assist the clinician in understanding the patient's pain and to help develop an effective individualized treatment plan. We know that every patient's pain and pain experience is very different, and the treatment for patients, one glove does not fit all. And so we're really trying to focus on creating a pain protocol that will certainly be very individualized to that patient. But first we must understand the patient's pain. So it's a two-way street. We also just recently received funding from the Sickle Cell Disease Association of Canada. So thank you so much. A big thank you to them for their support in this. And this project looks at sickle cell and hydroxyurea, looking at the barriers for compliance. We just finished a survey and had great response back from that. Very exciting. And we're hoping to develop a variety of educational tools to assist clinicians with education, hydria teaching. And also our main goal is to help develop a guideline or a protocol for nurses or pharmacists to follow that will help them, will help the patient to get to maximum tolerated dose so that they don't have to wait to come into clinic before we can escalate their hydria dosing and such. Next slide, please. So the future of sickle cell disease. I'm super excited to see what the future of sickle cell disease holds. Certainly, I feel like we've done a lot of work, but there still certainly needs to be done more. As you know, we're making huge advances in the treatment with bone marrow transplant and the gene therapy that we heard, as well as some new medications that have just been approved in the USA. We certainly need to continue with ongoing research and clinical trials for new treatment. We need to continue to advocate, to collaborate, and to work together to create some guidelines and to create some consistency that will help improve the care of these patients. I can't express how truly blessed I am to be part of this amazing team and to be part of all the great work that our clinic has done. I certainly will continue to work hard and to improve the care of these patients. Next slide, please. Questions?
Thank you, Trudy. That was really informative, and I think comprehensive care, as we all know, is really important. One question I have, and please, for everybody in attendance, please continue to share your questions in the chat or in the Q&A. So one question I do have for you, Trudy, to start off is, I know right now you'd said that you are working on research regarding sickle cell disease patients and the use of hydroxyurea. From your experience, which is a lot of experience with sickle cell disease patients, a lot of work there, what would you say are maybe some of the biggest barriers or myths, just from your thoughts and knowledge right now about sickle cell, about using hydroxyurea?
Certainly, yeah. So in doing this survey that we just finished, some of the barriers we already knew about. Obviously, cost seems to be one. So, making sure that we have patients' insurance coverage is essential. And so we get our social worker to help with that. One of the big ones is, they heard a family member or a friend who tried it, didn't like it, or had side effects. So that's one that often comes up. And certainly probably the biggest one would be the cancer risk that they tend to Google. So I think it's important for, clinicians to really have a variety of educational tools that are available, that we can, kind of take away all those myths and answer the patient's questions. We have recently had a pharmacist that has come to our program, and he has been instrumental. He sits down with the patient and really reviews and goes over the teaching and I think more thorough than maybe the physician has time to. So I think that's been very important. So we'll see what the outcomes are later. I think we may send out this survey again in a year or two, just to see if there's been any different comments or barriers that came up.
So what I'm getting is, when people have questions about hydroxyurea, not only to rely on Google, but to talk to their hematologist, their nurse, pharmacist.
Yeah, I would say, we often tell the patients, please don't go home and Google it. If you have questions, please call us. And certainly we would like to answer those questions. We're all guilty of it for Googling stuff. And obviously with hydroxyurea not being one of the primary indications being sickle cell disease, obviously, the first thing that comes up is the cancer stuff. And so it's been a big question for us in the clinic, always.
The next question we have is, does your team collaborate with your counterparts at the University of Alberta Hospital? Because I know you operate out of Calgary.
Yeah, certainly. Over the years, we certainly have. Anytime that we are at meetings together, we try to collaborate. I think we can do a lot better at this, certainly so. But we have reached out and we have, shared educational stuff, or sometimes I know the sickle cell nurse in Edmonton, and so I will reach out to her, and if I have a question and say, hey, I'm running into this, I don't know what to do. Have you experienced this? Do you have any, educational tools? Do you have any advice? And so we do collaborate, certainly. But I would like to see a little bit more. Certainly, I would like to collaborate on creating kind of consistent guidelines and such.
Okay. That's good to know that in the future, more collaboration is going to be coming through. The other question I have is, or that came from attendees, is what would you recommend for your patients right now during COVID to kind of stay healthy, stay safe?
Oh, this question comes up a lot. So, I've just been telling our patients that certainly, it's having sickle cell disease doesn't, you're not any higher risk of getting it. But if you do get it, you certainly are at more risk for complications. Dr. Ritz is actually hosting an educational session online August 20th, and we'll be looking at some of the data from the US about those complications and what the outcomes look like for sickle cell disease. Certainly, I would say, probably you just need to follow what guidelines are being put out by your provincial and federal governments and medical staff. Staying healthy, staying well, all those things that you're supposed to be doing, hand washing, staying away from people who may be sick, obviously no traveling outside of Canada. So just all those regulations that certainly are in place already.
Got it. Okay, thank you for everybody who sent in questions. In the interest of time, we're gonna have to move on, but like I said earlier, please continue sending in your questions. We'll work with Trudy to get them answered and shared on our website. Thank you, Trudy.
Thank you so much.
Now we're going to be moving on to a presentation from Biba Tinga. Biba has been dedicated to sickle cell disease for a long time for over 30 years, as a result of the fact that her first child was born with sickle cell disease. Since 2008, she's been active with the sickle cell community and has had several leadership positions in Canada. She has leveraged her parental experience in experimenting with new medication, evaluating treatment options, managing the risks associated with sickle cell disease and its various complications, and to advocate on behalf of patients and families in Canada. She holds a bachelor's degree in business management, speaks lots of languages, so she's fluent in French, English, and a couple of African languages, Zarma, Hausa, Wolof. I'm not sure if I'm pronouncing all of them correctly. She's currently the president and executive director of the Sickle Cell Disease Association of Canada. And prior to that, she was vice president of the Association de Anémique Falciforme de Quebec, so the provincial organization of sickle cell disease in Quebec. In her current role as the president and executive director of the Sickle Cell Foundation of Canada, she focuses on increasing education and awareness around sickle cell disease trait, as well as developing a communication and engagement strategy that puts those living with sickle cell disease at the forefront of the debate. Biba is going to be presenting the highlights from the national organization, new drugs, and new outreach programs. Thank you, Biba.
Thank you. Thank you, Abisola, for this great introduction. Thank you, everyone, for being here today. It's really a pleasure and an honor for me to attend this the Sickle Cell Foundation of Alberta's AGM. It has also been a privilege and an honor for me to welcome the foundation as a member organization of the National Organization for Sickle Cell Disease in Canada. And it's been really a pleasure again working with Ms. Jean. Very engaging, always the first to respond, always the first to provide information when it's requested. So as Abby said, today I'm going to talk about, national, highlight what we're doing as an outreach program and our mission, and also tell you a little bit about what's going on nationally. So next slide, please. I want to tell you first who we are. The Sickle Cell Disease Association of Canada was founded in 2012, which is pretty recent compared to some other sickle cell provincial groups, like the one in Alberta, in Ontario, and Quebec. So as you can see on this map, everywhere where it's red, that's where we have representation. And I was very pleased to add Alberta and the Northern Territories this year after we welcome you on board. So the only province where we do not have representation at this time is Saskatchewan, and we're working on it. And if there are any patient and family members watching from Saskatchewan, please send me an email. We want to work with you. We want you to be at the table. So, and again, our mission, is to better the quality of life of people living with sickle cell disease in Canada, wherever you are. So please join the conversation, stay at the table, and then let us hear your voice. Thank you. Next slide, please. So now, new innovation in the treatment of sickle cell anemia. Here I have a list of what we've had so far. Antibiotics. Everybody, like, if you are a patient, you are a caregiver or a healthcare provider, you know that, this is what we've been using for over 40 years. Painkillers and anti-inflammatory, vaccines, L-glutamine and dairy, hydroxyurea, blood transfusion. And we know the high risk with blood transfusion, that sometimes there's the higher the iron overload, and the reactions. And then we've had the bone marrow transplant, the only cure, but not for everyone. Only, I think, 10% of the patients are being offered, to go through the bone marrow transplant. So, but this has been supportive care only. It's not, it doesn't cure you. And we know that also, even with this, people have been going through a lot of pain, and what works for one patient might not work for the other one, because sickle cell, affects us in a different ways. So this is what we've had until the next slide. Now, new era. Our hope is materializing. We've been waiting for so long, and we've been very patient, patient group, families, and have been telling, have been saying it for a long time that, sickle cell is a forgotten disease, we don't have many options. And if we do, sometimes, access to care has been an issue in a lot of places. And so now we have changed. New drugs have been approved by the US FDA. So Novartis has this new drug, that has been approved on November 15, 2019. At the end of 2019, has I been telling everybody that 2019 should be put in everywhere on the calendar that has the sickle cell year, because we've had this new drug that is a monthly infusion to prevent vaso-occlusive crisis, brain crisis, because it makes the sickle cell less sticky. So the commercial name is Adakveo. We're talking about it, I think, during the dry run. So that's the name that you should maybe try to remember rather than trying to memorize the crizanlizumab. That is a medical name for it. So it is considered as a breakthrough therapy because it has the potential of preventing, the sickle cell crisis. So now we're moving from supportive care to prevention. That's a good thing for our community, right? And then we also have this other drug from the Global Blood Therapeutics, GBT, that was developed, and it's Vexelator, and the commercial name is Oxbrita. And it's an oral, once daily therapy that keeps the red blood cell from sickling also. It was approved on November 25th, 2019. Again, 2019 should be our year. Mark it down. And then another option also that we've had lately is the L-glutamine, Andari. It's an amino acid by Emeris Life Sciences. It's an oral therapy. It's still under review by Health Canada. And I must also say that for the Novartis drug, we've started clinical trials in Canada, in Quebec and Ontario, which means after that, it will be under review when they will, with Health Canada, before the drugs is approved for Canadian patients. Next slide, please. Now, gene therapy. I'm not going to go into all the details because you've had great presentation, from Dr. Turner, and also I think Trudy touched part of it here. So a universal cure, is it going? That's what we're looking for, right? So gene therapy availability, I put 2 to 4 years in this slide. I'm not sure that it's really going to be available for the patient community in 2 to 4 years, but I'm hoping that, I remember the first time I did this presentation was in 2019. So I used this slide to say maybe in 2 to 4 years, we're gonna have, a patient will be offered the possibility to have gene therapy, gene editing, especially that one, in Canada. I'm not sure. I'm hoping it's gonna happen, but that's the hope for most people who are not candidates for bone marrow transplant and are going through a lot of complications. Because as you know now, patients are living longer, they're getting older, but the quality of life is not the best for the sickle cell community. And even though we are told that, well, you have more options now and you're doing better, there are new treatments, patients are losing their life around the age of 50. Personally, I'm around 50 years old, and I think I have, I'm healthy, I'm very productive, and I see people around that age, and they have a lot of, organ damage, a lot of complications. Their energy level is very low, and the quality of life is not the best. So we're hoping that, this will change. So CRISPR Therapeutics, I think we were talking about it earlier, asking about gene editing. This is one of the pharmas working on it, and I believe the first patient in the US was last summer, 41 years old. And again, with this, I believe, I was told recently by one of the Canadian physicians that the US FDA is asking for 15 years, follow-up for patients who have gone through this therapy. So it means that if we have to wait 50 years after the first patients receive this care, it's going to take a long time before it's available for the patient community. So we need to be aware of that. Next slide, please. And again, this is Dr. Brita. I just wanted you to see it, and this is a new era of hope for our community. And again, these new drugs are not available in Canada yet. As I said earlier, we've started clinical trial for the Novartis drug, but not for this one. And this one is the GBT drug. And this is where our role as patient group and as advocate and as people supporting the community becomes very important and instrumental into getting these drugs to Canada. Next slide, please. So, as you know, with this kind of, with this new hope and everything that is new, with every new opportunity comes some challenges and some obstacles. In our case, we have obstacles, and I'm going to list them here. With gene therapy, I've just said it earlier, is the years of monitoring before it's classified as occurred, and also the high cost. And that cost can be a barrier for people to have access to it. And then we have the long review process. It can take up to 2 years for Health Canada to review a drug safety, meaning that, for example, the L-glutamine and dairy has been in review for the past 2 years and is still not available. So that's a long time for us to wait. When we look at it, a drug has been approved in November in 2019 in the US, and we still do not have access to that in Canada. And once they submit it to Health Canada, if it's going to take another 2 to 3 years, meaning that Canadian patients might have to wait maybe into early 2024 to have access to a drug that the American patients are already using. And what is the main obstacle here for us in Canada is the Canada drug prices. Cutting the costs could impact research, development, and future access, because these farmers might refuse to enter the Canadian market early on. They might choose to go to other countries like Europe and like in the US, but then not Canada. So our role will be to make sure that our community is not forgotten, because a small number of patients does not make an attractive market. And unfortunately, that's how it is, right? Next slide. What can we do? What can we do as a community? What can we do as a patient group? Our role is to advocate for the best care possible for the sickle cell community. But we cannot do it alone. I said here, we can't do it alone. No, we cannot do it alone. We have to bring people together. We have to get organized. We have to unify, and we have to educate our community, our policymakers, and also the healthcare providers. Sometimes, there are some specific information that has to come from the patient community. So our priority is always to access the new therapies. So we educate the patient population to participate in clinical trials, because Health Canada will not base the decision to approve a drug on the information that was done in the US. So we need to know that when your physician talks about a clinical trial going on, is that patient, if you are a candidate, you should listen to them and you should participate. Otherwise, we cannot have the data we need to present this drug to Health Canada to be approved. So it's very important that, we did that in November, as Ms. Jean was mentioning, at the research focus meeting. And every time we have an opportunity to educate the community during our webinar sessions, conferences, we always have a session, presented about clinical trials and the importance of getting informed. So I really encourage you to go to, clinicaltrial.gov and see what is available in your area where you live. So we also have to push for the priority review process, when a drug is submitted for approval. So we need to be involved in the process. We need to stay informed, to stay connected with both the farmers and Health Canada to know how the process is going, and if we have to bring our support, coming from the community to tell them how important it is. Because I am going to quote one adult patient who was we're talking about all these new therapies and this cure option, and he said to me, "I don't think I want it." And I was saying, "But don't you want to be pain-free? Don't you want to feel better and have a quality of life?" And he said something very important. He said, "But Biba, what good will that do for them and for me, to let them fix a broken body?" And I can share so many stories with you. We have this young adult patient. He's 46 years old, lives in Quebec, and he has kidney failures, so going 3 times a week for dialysis. And he's also he has to continue the blood exchange. As a result of that, he can't work. When you have to go 3 times a week for dialysis for your kidneys because you have kidney failures, then you still have the blood exchange, and you know how when you're anemic, it can be very difficult. And at this time, I think he's also facing a heart failure. He's 46 years old. So today, I don't know which option here can be presented to him that can really help him. We all know that, the options are very limited for him. So that's why we need to push. We need to push for the fast push, really priority review and to go faster. We cannot afford to wait. Our community cannot afford to wait. After 40 years, if something is available on the market, we need to have it in Canada. So what are we going to do? We need to engage the key partners. I've been working closely with CORE, the Canadian Organization for Rare Disorder. And I remember the day before we went into the lockdown, I was in Ottawa. We were advocating for this new drugs access. And we were telling them, you need to stop this new guideline that, that they want to put, on the drug pricings. And we need to come at the table. It's a discussion between our government, the pharmas, and of course the patient community. We need to look at what's best for everybody. So we have to make sure that our government does not forget about us. This is when I'm going to put the call, to the community. Your care, you are the key actor, when it comes to your care. The first thing you have to do is show up at your doctor's appointment on time, do not miss them, and listen to your healthcare providers. That's the first step. And you also have to know that for us to have access to drugs, because healthcare is public in Canada, we need to work, in partnership with our government, provincial, federal, even though healthcare is provincial. But this is what I'm going to tell you. So when we get to that stage, you need to know that democracy, it's about numbers. And as sickle cell community, we have 6,000 people living with sickle cell disease in Canada. And you look, in diverse community, we are a community people, as I like to call it. So you take one sickle cell patient, you look around them, they have a huge network. So this is where you have to understand that your voice matters. Your voice is very important. So stay connected, be engaged. When you're asked to send a letter to your Minister of Health, to your provincial Minister of Health, when you're asked to show up, for an advocacy event on Parliament Hill, you have to show up. And you have to vote. And you have to vote for those who care about your cause. Next slide, please. So we are getting ready. We are ready. We'll be ready. So as part of what we're doing now, ACJC is currently working on a national registry for sickle cell disease. It's going to be the first one in Canada. And I'm very pleased to announce that we've received a grant from Pfizer Pharmaceutical to establish this grant. So it's going to be, we're going to collect data on patients, diagnosed with sickle cell in order to facilitate, a wide variety of research. Trudy was talking about sometimes reaching out to other colleagues to ask, have you had this case, So this registry can help her get the information right from a click, right? If a physician, a nurse, and a practitioner is putting information from Quebec or Ontario, she's sitting, in Alberta, and she can have the information there. That's why we want a registry that is not only going to be a simple census, a simple database of patients, we also want a medical component of it. That's why we're trying to collaborate with CanHIM so that we have that data, in this registry. So it's going to determine the disease prevalence, access, quality of life. That's what I was talking about. When you are 46 years old and you're facing all these complications, don't tell me that there is quality of life with sickle cell when you get older. And even when you're young, and stigmatization is there, and being called a drug seeker is also something that, we want to address in the community. And we're going to also improve, and we also improve the standards of care, and we also want to try and evaluate novel and existing therapy in a real-world setting, meaning that what you've had now and when you have those new options, the difference, in the care, how does it affect you positively? What can we do better? What can we change? Next. So this is how this registry is going to look like, core ecosystem. So you have the registry here. So we have the researchers, the government, the industry, the clinician, healthcare system, investigators network, patient organization, because we are going to be, the one talking to the community, telling them to make sure that, when you receive that email telling you to log in and put your information, please do. It's going to be safe, it's going to be secure, and we are going to retain the control on this data. So your data will be safety stored, only used, for research by patient organization and the clinician who need it, right? So we want to know who you are, how old you are, where do you live? One of the key things, if you look at every single sickle cell patient and ask them how long they have to travel from the place they live and to go and have access to care, usually it's a long distance. And you know how sickle cell can be painful. You don't want to call an ambulance every time. You can have a spouse, a partner, a friend, a girlfriend, a boyfriend, or your mom or dad, drive you. But then if you have to drive more than half an hour, or even, I would say that's the minimum that they will drive sometimes to have access, or to go for your treatment, for your physician appointment, it's a lot. So we wonder why it has never been thought that, okay, let's look where these clinics can be established close to your community. And that's also part of the quality of life, right? So this is how it's gonna work. You're gonna receive information from us. We're gonna hold webinars, to inform the community about how this registry is going to look, and we want you to participate. Thank you. Next. Here, a sickle cell patient, getting blood exchange. It's just to show you, the reality so far. If you don't have blood transfusion, then you have blood exchange. I know that in Alberta, the Sickle Cell Foundation of Alberta shared a very good video put together showing Michelle getting her treatment. So I'm pretty sure it's on the website. If you've never seen it, I really encourage you to go and watch it. So this is life for them every 6 weeks, every 7 weeks, depending on how, your physician decide. This is life for them for now. And this young man happens to be my son. That's not his favorite picture, but I always share it because he gets annoyed about me doing that. So, and he goes every 7 weeks for his blood exchange. Next. Now, when we talk about blood, that's the next thing. We rely on blood, for the treatment of sickle cell. And we know that, the physician community and also CBS has been telling us that, that we need blood from diverse community. And there's been a challenge collecting that blood. So the first thing we did is a Sickle Cell Disease Association of Canada has been working for a long time with CBS in the rest of Canada and Hema-Québec in Quebec to just, encourage. So we hold blood drive. This year, we know that we've been hit with the COVID-19 pandemic and we're not able to hold any blood drives, but we do have a PFL number with CBS. And what is this PFL number? It's a number that identifies us, as a sickle cell community, as advocates. When somebody goes to donate blood, before you donate the blood, you have to go on the website and register with this PFL number. What is this going to do? Wherever you are in Canada, whoever you are, if you register, on their website and then you donate blood, it's going to show up, this number is going to go towards sickle cell. And we are going to be able to know that somebody has donated blood to support the sickle cell community. And at the end of the year, I always receive a full report from CBS that shows me province by province how many people have donated blood using this PFL number. And we have a yearly pledge. And I'm not very pleased to tell you that from such a large community today, we were not able sometimes, to reach the goal of 100 donations in Canada. So that's when the Sickle Cell Foundation came on board, we start talking about it, and then I realized that they had this terrific project that they presented in November in Montreal, and then we start talking about it. Next slide, please. And this is when it's very important for us to collaborate, advancement through collaboration. So we are going to collaborate with the Sickle Cell Foundation of Alberta to make your PinSide app project a nationwide project. Because I know there is a presentation, so I'm not going to go into the details, but I saw that and I just called Ms. Jean. I said, I want to collaborate. I want to work with you. So we've already had a meeting with CBS. We've had one with an organization called Say It Loud. And I think that it's important for us because to have them on board, because I saw their mission, how they work. It's about Black pride and you talk to the youth. And this is exactly where we need to go and get the blood. The second generation somebody like myself or any other caregiver who had been into sub-Saharan region or any region and have had malaria cannot donate blood. But this second generation, they can, and they can save life. But we have to let them know about that. We have to share the message. And how can we reach them? When I saw the Pin Size App project, I was like, that's exactly the solution we need. So we are going to work together. We're going to launch this project very soon. And I'm so pleased and so proud that, you know, the Sickle Cell Foundation of Alberta is going to be leading this project. And we are going to provide any kind of support that we can for this, you know, to become, as I said, a nationwide project. So thank you again for your time. Thank you for listening to me. I hope I was able to to provide all the information that the community is looking for, and I'm open for any question. Thank you. Merci beaucoup.
Thank you, Biba, for that presentation. That was really good and inspiring. I think after hearing that, I'm definitely more moved to keep on participating and kind of helping things move forward in Canada. It's really important. For questions, right now, one question I'll have for you is, and again, for those participating, please continue to put in your questions in the chat or in the Q&A, any questions that you have for Biba. One question I'll have for you right now, Biba, is what would you say, for people leaving this presentation, what is the next thing, like tomorrow morning, when they wake up, what's the next thing they should do to help move things forward?
If they can donate blood, let them donate blood, because that's the easiest way to save a sickle cell life. And use that PFL number, register online. And if you cannot donate blood, because maybe you are a carrier, maybe you have other conditions, recruit blood donors, become a blood champion, you know? Talk to your colleague, to your neighbor, if you go to church, if you go to the gym, whatever you, even in the bus, because we have those cards available, you know, to share. So ACDC can send them to you wherever you are, and you can share them and you can, you know, donate blood. And also stay connected to your local sickle cell organization. Support them financially if you can. Donate, because you know what? We don't have resources. Sickle cell disease is one of the forgotten diseases, you know, when it comes to, even our federal government does not support us. I must say, I was one of the first people to put a message on the social media when I saw what happened in Lebanon. And it was heartbreaking, you know, to see what happened, you know. And at the same time, I was looking, and right away I see how, you know, resources have been, you know, donated and given even by our government. And then I was looking, I was like, we're here, we're Canadians, we need support, and we don't have that. And we've been asking year after year, you know. Most of the people you see here have to leave their work, their job, and then this is something that they do on the side. And we need people, I think I would love to see every provincial sickle cell group to have a program coordinated, you know, paid with the resources that we get from our government. That's the only way that we can work effectively and better the quality of life of people living with sickle cell disease in Canada. So support, be a volunteer, give your time, donate, fundraise, do that. And then listen when we send out those messages to tell you, send a letter to your MP or show up for advocacy, show up. Thank you.
The last question I have before we move on is, I think you spoke in your presentation to the stigmas around having sickle cell disease. Mm-hmm. From your work and over all the years, and what are your thoughts around what those of us here could do to help break down those stigmas? Because I think it's a big thing in our community.
Yeah, it's a big thing. And I must say though, this stigma is not only towards, how will I say, it's not like, let's say, we tend to say that, okay, sickle cell patients are, for example, viewed as drug seekers, you know, when they're seeking for cares. That's not the only type of stigma that we have. Also within the community itself, you know, we need to change our mindset. So the only way I'm gonna now address this to the patient community, share your stories, talk about what you're going through. I still know people in Canada to this day who are telling me, my colleague don't know I have sickle cell. I don't talk about it. I don't want to talk about it. You need to share. When people know what you're going through, they can understand you better, they can support you, and they can help you. So I think keep sharing your stories. Let's have the national conversation. Let's continue to talk every opportunity you have. When your local group calls you for a conference to come and share your patient, journey, or even a caregiver, the parent also, they have to talk, because the burden is on the patient, on the parent first, till it's then transferred to the child when you become an adult. But if you're not used to seeing even your parent talking about it, your first reaction will be to hide. And also this communication between us and the healthcare providers, I love it. I love the fact that today, Dr. Turner was here, Trinity was here, to present how they're working. It's going to help the patient community see. And, sometimes we get upset from small things and because just we don't communicate outside of the care system, right? So when we have this type of conversation where we meet each other and we create this platform for us to come and meet and talk and understand, okay, so this is how I can help. When I have this appointment, it's important, it's because, I have to show up on time and I have to listen. And then, maybe it's going to facilitate the communication between us. So let's engage each other.
Thank you. I definitely agree with you on patients sharing their stories. I think a lot of the times there's a lot of secrecy within our community, and we need to speak up more. Growing up, I really admire my mom for speaking up and like you, not making it a secret. And I think that's impacted me greatly. And I think that's all something we need to all do better.
Yes, we have to. We have to. And that's when, on June 19, and Alberta participated. So we had this virtual event called Voices, and we're going to continue. Our voices are important for people to know that we're here, what we're going through, what are our unmet needs. If we don't speak up, how can we be helped? How can we be taken into consideration when they're planning for the budget? In Ottawa, they need to know that there are 6,000 people living, and then they still are having supportive care in 2020, even though a lot of research is going on. And still, to me, we need to have access to more than that.
Thank you so much, Deba. This was really, really helpful. Thank you so much for joining us.
Thank you. Thank you. Thank you for having me.
So we're going to move on to the last item on our agenda prior to our closing message from Dr. Jill Horand, our president. So the closing item on the agenda is really interesting and innovative. It's research that has been done by work from the Sickle Cell Foundation of Alberta. So the research group for this presentation is made up of a group of STEM students working together to bring greater awareness to sickle cell disease. The students have worked together to develop the Mish pint-sized app, headed by Arnold with the social media awareness, by Papa and by Felix with the guidance of Kim and Wilson. So this research team working out of the Alberta Foundation will be presenting on Blood, You Have It to Give, and the Mish pint-sized app. I think we're just having some technical difficulty.
Doctor, you're muted.
I'll mute myself, but okay. So like I said, this project that we've been working on was an idea that was born out of realizing that visible minorities are not likely to donate blood. It took us a while to get where we are. Last year, we were able to actually go out and do the data collection, and this year do the analysis. We have 4 students last year, and this year we have another 4. So the 4 students who worked on this project this year are Dylan Jayachandran, Arnold, Papa, and Felix. Now, Dylan is a pharmacy student at the University of Alberta. He is actually working on his PhD in pharmacy. And so he's not available today because he's doing his rounds in his pharmacy practicum now. and today he has to work. So Dylan was the one who looked at the data we collected last year and actually fine-tuned it using SPSS, which is a social science research analysis platform. Anyway, so he gave us some research here, and this is he was looking after the quantitative aspect of the research with regard from the data we gathered. So Felix, do you have my presentation that I did last year? So his presentation, he was able to do some fine graphs and so. But what I would like to do is quickly show you all what we did and how we came to this junction. So Felix, next slide. Anyway, right as Felix is getting things organized, I will let you know something. The funds we were able to get were from the government of Alberta and the government of Canada to carry out this research. And of course, we were able to use some of the funds that we got from our casino fund. Okay, so the data what I'm going to present here is an analysis of a small portion of the 130 participants who participated in this research. And so these are the people who participated. There were some who had, I looked at about 19 people, and this was my basic small analysis before we did the major one. So we had some with secondary education, some had completed, some university and college, university graduates and postgraduates. So the one thing you'll notice about this data is it's based on the fact that those who collected the data, they spoke to their cohorts. And the people that we were looking for were between 19 and 34. So as you can see, they've got a fairly good level of education. Next slide. And the questions that we were asking were to find out their knowledge of blood and blood donation. So you can see from this slide here, the ages of the people and the knowledge of blood that they had. So you're looking at here now, and what you're seeing is that it was sort of all over the place. Just because you are older doesn't necessarily mean that you had a better knowledge of blood and blood donation. And I'll just go back and talk about it a while. What we did for our project was we interviewed 130 people, then we applied a treatment. And the treatment that we applied was Michelle apheresis treatment. And if you haven't seen that video, you should go on our website and take a look at it. And after we showed that video, we went back and asked them a few more questions about if they were consider participating in blood donation once they realize what it takes and who needs it and how they can be helpful. So it was an education process for them as well as a research process. So next slide. The people that we were looking at, we wanted to see visible minorities. So we looked at people who were African diaspora, South Asian, and Asian. So as you can see, depending on who we got information from or who we got to do the research as the researcher, this is where the data was collected from. So if you look at this, you'd see very few people of Asian heritage. And so this is one thing that is lacking from the research. However, we were able to get people from the Middle East to participate in the research. Next slide. And these are the average knowledge of blood, and you can see the African diaspora based on the questions and how when we combine the questions that discuss the knowledge of blood, this is how it turned out. So the South Asians had a little bit more knowledge of blood than the Blacks. Keep going. And the fact that Blacks have a little bit less knowledge of blood could very well go back to could very well go back to their concept of if their blood will be accepted if they went to donate. Because Charles Drew was the first person who looked at transfusion as a way of saving lives. And so the old wives' tales and it's probably not true, was the fact that Charles Drew was a Black doctor. He did some of his studies at McGill University, but he was from the southern part of the state. And the story that has circulated was the fact that he got into a car accident, and when he needed blood, there was no blood for him to get, so he died. But there was always stories about how Black blood was treated as blood that shouldn't be used, and they discarded it. And so when you talk to some Black people, they'll say, well, they don't want my blood anyway, so why would I go and donate it? So when we asked the question before the treatment, have you ever donated blood or recently? This is what turned up. 2 of the people that we interviewed said no, and about 13 said, no, 2 said yes and 13 said no. So keep going. Next slide. The data that showed up before, detailed donation history before treatment. Some of them said they never thought about donating. Some of them said they never thought, but they would. And some of them said they recently volunteered to donate blood. And as you can see, among the volunteers to donate blood, again, it's not very much. And this was a small sample that I used of the population that I looked at. Next slide. Okay, so then we applied the treatment, and keep going, Felix, which was the YouTube video. And after the treatment, we asked the question, will you donate blood? And you can see there's a change. More people said yes than said no. Keep going. Have you ever seen or heard any discussion about blood? And some said no, and some said yes. Keep going. But it was kind of telling when we asked them, well, what's the best way for us to disseminate information for finding out about blood? And you can see social media was the one that scored the highest. So based on that information, well, I always thought that was probably a way to go. I thought that the vehicle to get people to donate blood would be to go through developing an app. So I'll turn my discussion over to Arnold now, because Arnold is the one who is looking after the app. So Arnold, you can get started now.
Thank you very much, Dr. Warren. So as Dr. Warren mentioned, my name is Arnold, and for this summer, I've been working as a software developer for the Sickle Foundations of Alberta. So I'm currently studying Bachelor of Science in Computing Science. I'm heading down into my final year of a 4-year degree. And outside that, I'm very involved within student governance. I am the president of the Augustin Students Association, which is the faculty, one of the faculties within the University of Alberta. And then this summer, I've been tasked in developing an app for both that runs on both Android and iOS in regards to that. So some of my roles included designing the architecture of the project. So looking at how the app will be working both on the front end and the back end of the application. So that led me to designing an application that was both working on iOS and Android using Flutter, which was a cross-platform developing tool. So right now, the work that has been completed is that we have done most of the front-end development, meaning the screens, the transition, and the design. And so that took quite a bit of the month of June, where we were developing all those framework and ideas. And then the month of July has been mainly focused on the back-end design. So that includes creating our database, the logic of the application. So in other words, how the information is being processed, the data retrieval and loading. So the connection, the communication between the app as well as the backend, which is for backend, we're using Firestore, and data storage, test cases, and security. So the last two are still an ongoing process since again, we're just done the very beta version of the application. We're still working a lot into those test cases, trying to find those bugs in order to be able to solve them. And the security aspect, it's just coming into play right now as we're talking. So next slide. So if we look at here, this is some of the screenshots of the application. So the application has the ability of letting the users to log in, either using a Google account or just simply creating an account with us that will be stored within our database. So right now, as we speak, the goal of the application is to be able to encourage people to go donate blood. So we were hoping to be able to do that, all of that from the applications, meaning creating campaigns, creating donations, donation thread and blood drive. However, in order for us to be able to do that, we need a connection to the Canadian Blood Services. So again, that's still an ongoing process that we're trying to do. Right now, what the app can do is you can book an appointment for Canadian Blood Services using the app. Anytime you click that blood icon at the bottom of the screen, you're being directed to the Canadian Blood Services website. So if we go on the next slide, we can take a quick look at the app. So when you open, you're greeted within the login screen where you can log in with your email and password if you have already set that up. And then once you log in, you're greeted with the number of donations you have done for that specific month. And again, the reason why I went with that circle is it encourages people to be able to donate more frequently. You can access the news. Right now, the news are connected with the the Sickle Cell Foundations of Alberta website. And you can also donate blood using that link or clicking that button over there, which will direct you to the CBS website. Once you're done, you can just simply log out of the app. And if you don't have an account, you can sign up using clicking sign up below, where it will ask you a whole bunch of information such as your first name, your full name, email address, and password. And once you have inputted all of that, then the app will be sending a confirmation email to that specific email address. And once you have confirmed that email, then you will be able to log into the app. And the reason I did that is we want to prohibit having both bots that log into the application. So by sending a confirmation email, I want to make sure that anyone who's using the app is actually is a real person behind it. So next slide. So some of the next steps onto this project is continuing working on that security aspect, improving some of the user interface. So as I said, in the mostly of the month of July has been working on the database aspect of it. But right now we can go ahead and start improving some of the user interface. One of the biggest one actually is connecting the app to the CBS database, because that will increase the things that this app can do. And of course, as within any software project, just continue bug hunt and fixing as they come. Yeah, thank you.
Hi, my name is Papa, and this summer I worked on the social media campaign for the Sickle Cell Foundation of Alberta. I'll just tell you guys a little bit about myself before I get started. I'm a third-year chemical engineering student at the University of Alberta, and I'm going into my fourth year next year. For the community, I help out my church. I coach basketball, and we also run a twin and triplets festival every year. So next slide. So I'll get into my role and what I did for the organization this summer. So my main role was to post a minimum of 3 times per day on our social media sites. That type of content was designed by me and Kim, Ann, and Felix. And those types of posts included did you know, fun facts, links to articles about new findings of sickle cell disease, and memes. Next slide. At the beginning of the campaign, we pushed for people to send in video submissions about how sickle cell disease has affected their life, so we could repost that on our social media sites to build awareness. My second role for the campaign was to design 2 templates for the campaign. These templates included the SCFA colors of red, orange, and rust. We had circular dots on the banner to represent blood cells. And we also developed hashtags for our campaign. So these hashtags were sickle cell disease, sickle cell awareness, Alberta, and YAG, just to make our post easier to find. Every week, I would also track the amount of followers on our Instagram, LinkedIn, Facebook, and Twitter sites to track our progress. So we made a lot of progress this summer. Basically, our Instagram followers, we started off with 257, and by the end of the summer, we had 366. Our Facebook followers went from 229 to 262. Although our Twitter and LinkedIn profiles didn't see as significant amount of growth, we're still going to work on those and have them improved by next year. If you proceed to the next slide, the following, these 3 posts did very well. We gained almost 300 views on each of them, and we had a lot of people comment and share on them, which was really good. So overall, I'd say it was a very successful summer, and we got a lot of engagement. We gained a lot of followers this summer, and the design of our page as well, and we have like a lot more engagement on all our social media. And that's all for today.
Hi, good afternoon, everyone. My name is Felix. So throughout the summer months, I work with the SCFA as admin assistant as well as a coordinator in between with the app, as Arnold worked on, as well as the social media campaign. Sorry, once again. I'm currently an 8th student studying electronics engineering, going into my 2nd year. So throughout this year, I've been here since 2019. I continued on the work we started in the summer, and we've seen a tremendous amount of growth. As Arnold mentioned, we've started the app, and as well we continued iterations of the app, and as well as adding functionality to help in the awareness of sickle cell disease, as well as in the awareness of the importance of blood to patients. So here's an example of our progress map. This was at the beginning of our 10-week period. So throughout that time, from originally the 10-week period of June 3rd, we have grown a lot. We have seen so much engagement, as well as education of individuals, sickle cell patients and non-patients, in the importance of blood, importance of donation, and as well we've made connections with other external organizations such as Say It Loud for us to be able to facilitate our Misha's pint-sized challenge starting next month. And as well as as Papa mentioned, we had called for submissions from patients to submit their videos, and these videos were used to educate individuals about how sickle cell affects patients. And as well, some of the videos were used in conjunction to a promotional video which we have created, which will be on our Facebook and our Instagram, to share the lives of sickle cell patients, and as well to emphasize on the importance of blood donation, as well as to also garner monetary funds to help further our research projects and as well our education projects in the community. Looking forward throughout the year, we're continuing on our path of more awareness, more education by introducing items such as games, weekly games on our Instagram pages as well. So those games will be more educational focused, such as the ones you saw during the polls that we did today, items like that. And as well, we'll be providing more information on our website and our ever-growing online presence throughout Instagram, LinkedIn, Twitter as well. And we do encourage you to follow us on those pages. It's all the same it is our SCFA on Instagram, Twitter, and Facebook. As well as I mentioned, as Biba had mentioned too, we're looking to work on starting a registry too for Alberta. So we'll be collecting some information on our website to help with the National Registry and as well for a registry for Alberta. Thank you so much.
Okay, Felix, before we end, one of the projects
the campaign video, sorry.
Was a campaign video, and it was launched yesterday. And for those who are attending, Felix, it's just I think it's a 3-minute video. Can you show it to them, please?
Yeah, sure. I'll go ahead and show you the campaign video. It can be found on our Facebook as well. 1 second here.
It's called A Day in the Life of a Sickle Cell Warrior.
Every morning I have to wake up and hope that it's going to be a day that I don't have a crisis. It's always on the back of my mind. My day starts like everybody else's day. I have things to do. I have appointments to attend. I have to make sure that Daniel's ready for school and that his needs are met. I have people that are relying on me. So I have to make sure that I'm keeping myself healthy and that my sickle cell doesn't affect my day. I've been crisis-free for a while, but I do still have some chronic pain that I experience in my shoulders and my limbs. And I do worry about it sparking up into a crisis. A crisis is when there is a lack of oxygen getting to certain tissues in your body, and it presents differently with different sickle cell patients. You can't predict a crisis. There are certain things that might trigger a crisis if it's too cold and that drastic change in temperature, any type of infection or illness. Even now during this pandemic, I had to be extra cautious because having an infection could be devastating for somebody with sickle cell. I'm a realtor, so I have other people depending on me too. When I say I have to show up for an appointment, I better be there. This video is about my story, my family, and my experience with sickle cell. But everybody has a different experience, and here are some of their stories.
Sickle cell causes me to be away from my kids and my family by being in the hospital sometimes weeks at a time. I've had acute chest syndrome that's almost claimed my life. Sickle cell matters too. Us warriors and our battles are important too.
What triggers or may cause crisis? I think the most important thing I keep repeating is stress. When I get myself involved in anything that pain or do give me stress. Then dealing with pain, I deal with pain by blocking things out and just like not thinking about it and putting myself in a quiet place in a warm environment and taking lots of water and medication. Difficulties in the emergency room. I think difficulties in emergency when you deal with stuff you don't understand what you have, and they make it very difficult for you because they don't understand how urgency it is for you to be in the A&E that you need to be seen.
The Sickle Cell Foundation of Alberta was created by patients for patients, and it was to bring awareness and support and to educate people on sickle cell disease. We need your help to make the lives of sickle cell disease patients better. Visit our website, make a donation.
So that's the end of our presentation. Blood, you have it to give. Misha's pint-size app. Okay.
Thank you very much for that presentation on the research. That was really good to see that we are moving forward on that perspective from the app. And for anybody attending who is interested in helping test the app, the beta version, and getting involved in that process, please feel free to send us a note and reach out to us, because we will need help with testing the beta process, the beta app. And that video, like many people in the chat are saying, is amazing. And please share. I know we're over time, but the last thing on the agenda is a closing remark from our president, Dr. Jin Wilran.
Okay. Thank you all for attending this AGM. It's, in my opinion, it's humbling to me, and it was because I think it was amazing that we were able to bring people together to spend 3 hours with us on a Saturday morning when I look through my window and the sun is out. I want to thank Biba for coming. I want to thank Dr. Turner for presenting. I want to also congratulate Dr. Turner on the fact that he won the Mary Burley Award. I want to thank Stephanie for answering my call to come and sing and serenade Dr. Turner on his remarkable achievement. And I want to thank everyone who signed up and to participate and keep in touch with us. I want to also thank Bernice and Abby for doing such a good job, and of course Felix for doing such a good job in putting this program together. Most of you, I had nothing to do with it actually. I just left it in their hands and they did a good job. If I have missed anyone, please, I didn't mean to. The board, I am happy to have you all, and I'm happy to have you all continuing to work with us. As I close, I want to let you all know that for Sickle Cell Awareness Month in September, we are hoping to put on this challenge that is going to be across Canada to see which province can donate the most blood. We will send out our notices and our invitations. So I'm asking all of you from whichever corner of Alberta, not Alberta, from Canada, from coast to coast to coast, to get involved, get people to donate blood. Your blood is one of the best things that you can give altruistically. And it is very much needed by your friends and so on. We know now that the genetic component of blood is extremely important. Even if you have O, AB, or A, or B, positive or negative, now that we know more about genetics, the genetic component causes people to have less reaction if they are close together genetically. And when I say reaction, people who take blood like 7 pints every 8 weeks or so, you'd see them itching and scratching because their body is saying, well, what's that foreign object? But when they're close together genetically, that itching and scratching goes away. And I noticed that with my daughter. So come on board, let us show everyone that we can do things by us, for us. We're going to be working with the group Say It Loud, as was mentioned, and hopefully it will be successful. And it's a project that we will do a few times a year. World Sickle Cell Month, the Sickle Cell Month, and during Black History Month, we can think about doing something like that that's altruistic. So spread the word, okay? And thank you once again for participating and making this a successful AGM. Let's see.
Thank you, and I guess bye, everybody.
We will have all our stuff up on our website. So visit it.